Hi, Dr. Michael Miyazaki. Thanks for joining me again. Today, what we're going to talk about is some questions that are coming up. We've been talking about the indicator for the last couple months. We've had interviews with like Dr. Ryan Walsh. We've had other endodontists like Dr. Gilbert, Dr. Short, Dr. Cross, who are all big proponents of using the indicator. But those of you that are trying it out now have some questions. So I just want to kind of go back. In doing this, I'm addressing some other questions that we have. When we do a root canal, we can follow our protocol. It could a certain file system, a certain sequence we go through, a certain irrigation sequence that we go through that kind of matches our mechanical cleaning of the canals. But we really don't know when or how clean those canals really are. Are they clean? Are they clean enough that now we've removed enough of the bioburden, the tissue, the bacteria, and everything else that's in that canal? Have we removed that till it's spot clean? So when we seal that up, we know there's not going to be any bacteria that can cause another infection or maybe not allow the current infection to heal up. So a lot of us, and I was of this thinking too, thinking when I'm using my mechanical files that I'm really doing the cleaning. I'm cleaning, I'm removing the tissue, I'm removing the bacteria. Oh, and then I'm also shaping the canal out so I can obturate. But as I use that mechanical file, how do I know that I've gotten that bacteria down below a level where the body can then heal itself up? Did you know as I use that file, I'm creating a lot of dentinal mud. I'm mixing the bacteria out with the blood that could be in there, with the purulence that could be there, and it's all becoming one kind of cloudy mass within the canal. If I wasn't using the irrigants that we've talked about during our past programs, maybe I was using sterile water. Sterile water to lubricate my files, to get all that dental mud out of there, to rinse it all out. And I might be thinking, okay, now I can obturate because I've cleaned everything out and it looks good. Well, did you know that you really can't see clean, right? We can't see clean on, even if we have an endodontic microscope, I can't see clean. I can't see the bacteria that maybe we're leaving behind or that we have not left any bacteria behind. And if I take a radiograph before I obturate or before or after I obturate, I can't tell if there's bacteria still in the canal or to a level low enough where the body can heal. I don't know what clean is. And I don't know if I've achieved that level of cleanliness so that I can obturate. And I think that's one of the burning questions. And I did a program about that is when I obturate and I seal that canal up, sometimes I'm just praying that I have everything clean. What am I depending on? I'm depending on my protocol. So you have to remember that the goal of a root canal procedure is to clean the canals out, to get all that bacteria and tissue out, and then to shape the canals so that when we obturate, our gutta percha and our sealer can fit all the way down to our working length. Because a lot of times the canals are wider in certain areas, maybe more narrow. And if I'm trying to get my gutta percha down there and there's a narrow constriction in the canal, I'm not going to be able to get my gutta percha down. So part of the mechanical filing is to shape those canals. But yeah, we're also trying to remove the vital tissue, necrotic tissue, the bacteria, the microorganisms. We're trying to seal it up so that there's no blood that's in that canal. And if I don't clean those canals out properly, then the patient could have some postoperative pain. There could be some infection that persists because I haven't taken the bacteria levels down to a level low enough where the body can heal up that peripheral tissue. And eventually, if it doesn't get better, we have to do retreatment, which is not fun for the patient or whoever did the root canal. And if we don't get this to heal up, then we can lose a tooth. Bottom line is having to retreat after we've done everything properly protocol wise is not fun. It usually results in a loss of revenue and just for me, a loss of sleep because we want to do what's best for our patients. We honestly do. And we're trying to do the very best. And when you do a root canal, endodontic procedure, non-surgical, it is not easy to do. But when I obturate, that is like the icing on the cake. We're fully committed, right? Either I have the canal cleaned out or I don't, and I don't know. Now, with the file going down those main canals, let's say I have a single rooted or single canal tooth, and I have one canal, and I take my file and I'm going up and down. You know what? Even in a single canal tooth, there's going to be lateral spaces. So there can be collateral isthmuses that go away from our main canals into other parts of the tooth. How do I know if I get those clean? Because that main file can't make those tight turns. How do I get those areas cleaned out? And if I don't get those areas cleaned out, what's going to happen? So I want you to remember that filing creates a mess. It actually dirties up the canals. It's the irrigation that then cleans that out. And not only does it help us to lubricate and to suspend all that dental mud debris, and then when I rinse it out to kind of remove it from that canal, but when we're using our sodium hypochlorite, we're actually disinfecting and again dissolving the tissue that our files may not even touch. So I've shown you in past programs that studies show that when we take a file and we go up and down the canal, we don't always clean the canal out well because our files don't necessarily touch all the canal walls. And what this video is showing is, look at all the mud. When I look at the file in there, you can't see it because it's in a cloud. What's it in a cloud of? Well, in this case, it's a cloud of acrylic because we're scraping the canal walls. But in a tooth, that would be the walls, the dentin. It could be tissue, it could be blood, it could be the purulence that's in that tooth. Just all not good stuff. Now when we irrigate, the irrigant is rinsing all that out. It's disinfecting, dissolving the tissue, but it's removing all that dental mud. When we go back in with the files again, all we're going to do is we're going to make it cloudy again. So see, it just gets cloudy because we're scraping the walls and we're creating more mud. It's the irrigation that's cleaning this out. And so that's what we have to remember. It's the irrigants that clean it out. And this is just close up, just showing that file going into all that suspended stuff. And so imagine you're doing that root canal and you're taking your mechanical files, whether they be hand files, rotary, reciprocating files, as you're going up and down, scraping that tooth, you're creating all that mud, just suspending that bacteria. So that's the main area that we're trying to clean out. But remember, along those canal walls, we have those little spaces and maybe some lateral isthmuses that we cannot get into. And the small tubules can have bacteria hiding in them. So what do? Is we use a sodium hypochlorite because that's going to dissolve the tissue in those main canals, but the dental mud is going to plug up those tubules. What we're going to then do is we're going to use our EDTA because our EDTA is going to chelate all that calcium and all that dental mud, pull it out of those tubules. It's like putting our phosphoric acid down on a tooth surface before we put our adhesive in our composite. We're going to open those tubules up, and then we're going to go back in with the sodium hypochlorite because now the sodium hypochlorite can get into those tubules that were previously obscured. So it's like placing your phosphoric acid to remove the smear layer, kind of the same stuff, right? It's dentin remnants, tooth remnants, and we're going to remove that, and then we're going to open up the tubules, and into those tubules, our adhesive can now penetrate down in there to give us our micromechanical retention. So in this case, for the root canal, we're using the sodium hypochlorite to dissolve the tissue and disinfect. And then we're going to use our EDTA to remove the smear layer. It's a chelator, so it's going to open up all these tubules. Then we're going to go back in with our sodium hypochlorite, and we're going to use our activation to force our sodium hypochlorite into all these small spaces. And then we're going to be able to really, truly disinfect that tooth. Now, if that's our protocol, when I go back in with the indicator and I rinse out the canals with sterile water and then I withdraw some of that sterile water, I should be able to test it and get a low score because we've basically removed all the bioburden. We've dissolved all the tissue, we've gotten rid of all the bacteria in there, and if we've gone down a working length, hopefully we don't have any purulence or bleeding down there. But now we've got a nice clean canal, and that's what we're striving for. So remember, the filing doesn't get all the bacteria. The filing just allowed our irrigants to get down to the bottom of the canal so that our irrigants could then really get rid of the bacteria. And so that's one of the things I want to stress is it's not the filing. The filing is creating the mess. It's the irrigation that's removing that mess and then disinfecting the canals and getting into those lateral spaces and all those tubules where the bacteria is hiding. If we don't do all these steps during our protocol, we're leaving bacteria behind. And if we do our indicator test, we're going to have ATP and we're going to be able to measure that and know that we're leaving bioburden behind. So I think that's one of the most important things is we can't see this bacteria. We can't take a microscope down into canals and see down there. So the indicator gives us the EndoScore. And the thinking behind this is we do our protocol and the indicator is going to show us, do we have those canals cleaned? We're going to clean and then we're going to confirm. And we're going to clean and confirm before we obturate. And so that's going to allow us to detect how clean those canals are. If we have a high score, we've got bioburden. We've got to figure out why that bioburden is so high. But if I obturate with a high level of bioburden, there's a higher chance that we're going to have pain and the infection is not going to clear up. And this is not a judgment, again, on the clinician doing the root canal procedure, but every tooth is unique. So we can follow the same protocol, and for 9 out of 10 teeth, we can get a perfect result because that protocol, files, irrigation was good enough to handle those 9 out of 10 teeth. Then we get one tooth. The canals are a little different, or maybe there's more than the usual canals, and maybe not just by one canal, but maybe by multiple canals. And those are the teeth where the EndoScore will show us that perhaps we need to go back. So the EndoScore is much like golf. The lower the score, the better. But if your score is above 25, then what do we do? And this is where we're getting a lot of questions also, is if my score is not as low as we'd like, 25 or below, what do you do? Well, again, if you're doing the root canal procedure, you want to make sure that you haven't left any tissue behind. Does the tooth look clean? And if you dry it, does it look clean, right? So you have all the tissue out. It's no longer bleeding, and there's no purulence or pus coming out. Because if you've got tissue, you're going to have ATP. If you've got bleeding and blood cells in there, you got ATP. And if you've got pus down there, infection, you're going to have ATP. So if you try to take your EndoScore with all those issues, you're going to have a high score. Now that's a good thing because sometimes we can't see all the tissue, the bleeding, or the purulence in those small canals. And so when we get a high score, we go, okay, take a deep breath. Don't worry about it. Go back there and clean it. I'd rather know I need to do a little bit more cleaning now than after I've obturated and I have no way to get back in there and now the tooth blows up. Another thing to do is if you look at that root canal that you've just done your procedure on and you don't see tissue, you don't see bleeding, you don't see any purulence, but it still has a high score, then start thinking about, did you miss a canal? So go back in there, look down there with magnification preferably. You can even use a caries indicator to put in there and rinse out to see if you can pick up a trace of another canal or two. You could take a radiograph a little bit off angle that you've been taking them to see if there's canals that you can separate in a radiograph. Or even better yet, maybe stop and say, okay, I'm going to take a CBCT on this because I only see 2 canals or 3 canals and it turns out the tooth has 4 or 5. If all that is negative, the tooth looks clean, you've looked for canals, maybe even radiographically, and you don't see that you've missed anything, then maybe look for a root fracture. Because if that tooth has a root fracture, there's going to be cells that can get into that crack and you're going to have higher scores. Another ideal on this is with a root fracture is you could have an old restoration in there, and that old restoration is allowing bacteria saliva to get through it, and it's recontaminating your tooth. So it kind of goes along with the root fracture. Look for cracks in the tooth or the restorations. Another thing that I don't have listed here that I should put here is rubber dam. If you're not using rubber dam and the patient closes and saliva gets into that canal space, again, you can have a high score. And what do you do if you have what if you do this and everything looks good, you can't find a canal, you don't see a root fracture, you don't see that your any of the old restorations are leaking and you've got your rubber dam on, then go back in there, irrigate with activation some more, right? What you're going to do is you're going to just assume that somewhere there's more bioburden down there. You don't know exactly where, you don't exactly know how much, but just irrigate and activate some more and then retest. See if your score went down. If it hasn't gone down, then repeat. If you can't get the score to get low enough to your satisfaction on this day, then what I'd recommend is put some calcium hydroxide in there, let it sit for a week, get the patient back, remove the calcium hydroxide, just see what you got in there. If it still looks dry and clean, irrigate with some sterile water to flush it all out, and then retest and see what your score is. Again, realize that this is not a judgment on you. You could have a great protocol that 98% of the time works, but this EndoScore will help you detect that small percentage of times when maybe that tooth needs a little bit more work because in its own way, it's very unique. So anyway, I hope this covered some of the questions that some of you have had because we're having fun with this. More and more doctors are using the indicator every day. They're finding that it's showing them things that they could not detect before. It's helping them to avoid problems that they would have had they not used the indicator and gotten their EndoScore. So this is not something that's difficult to do. It's something that's kind of fun to do. It's like going out there and golfing. Personally, golfing isn't too relaxing for me. But if I ever do go golfing, the score is what makes it fun, right? You try to get the low score, shooting for the hole in one. When you use the indicator, that's what we're doing. We're shooting for the hole in one. When you get that score of 1, you feel really good because you've done about as good a job as anybody could. And when you obturate, as long as we do a good job when we obturate, we're going to have great success. So keep using the indicator, keep striving for those low scores, and just have fun with it. It shouldn't be a burden. It shouldn't be something you worry about. It should be something that you actually enjoy. All right. I will see you during our next program. Thank you very much.